Welcome back, everyone. We're going to continue through the neurology series with talking about headaches and other neurological complaints. An important note, we're going to discuss some treatments here that are only going to be relevant for paramedics and AEMTs. But as a new EMT provider, you should also be aware of the next level of treatments for each of these emergencies. So I would encourage you to listen through, even though the treatments may not apply to your certification level, to help understand what the next steps in the treatment process would be for these patients. So, for headaches, you should be concerned if the patient complains of a sudden onset or severe headache, particularly terms like thunderclap headache or the worst headache of my life, because this may be an indication of another underlying issue, such as an intracranial hemorrhage, a hemorrhagic stroke, or the onset of even an ischemic stroke. A sudden headache with fever, seizures, altered mental status, or following trauma should also be of concern and carry a high index of suspicion, as there may be other neurological insults that are underlying the symptom of a headache. Always make sure that you assess your patient for other signs and symptoms that can indicate a more serious condition. We should carry an index of suspicion with us at all times with patients, regardless of how benign the complaint may be. If they are hypoxic, make sure that we provide high flow oxygen. Oxygen is indicated for hypoxia, and we should treat accordingly. If it is a headache that is suspected to be of migraine or an origin that is non-serious etiology, then consider turning off the lights in the back of the truck, try and make it a quiet environment, and that will help alleviate some of the pain that's associated with a headache. Let's talk about some of the common types of headaches. First, we'll talk about a muscle tension headache. These headaches are caused by stress, altered cortisol levels, or depression. They can cause residual muscle contractions within the face and the head, and pain is generally felt on both sides of the head or the back of the neck. The pain is often described as a dull ache or a squeezing pain. The next type of headache we'll talk about is a migraine headache. These are typically caused by minor instability within neuron clusters within the brain and can be caused by changes in size of blood vessels at the base of the brain. A patient may report an aura or a strange feeling or visual hallucinations along or associated with this pain. And the pain is generally focused or unilateral to one side. Cluster headaches begin as minor pain, typically around an eye, and they intensify and spread to one side of the face. They occur in groups and they last about 30 to 45 minutes each. Sinus headaches are inflammation or affection within the sinus cavity that causes increased pressure in those sinus cavities, resulting in that pain. The pain is typically isolated to the superior portions of the face and can be accompanied by postnasal drip, sore throat, and nasal discharge. As far as management for headaches, a headache can indicate, as noted earlier, a more serious condition. It may be a symptom of a more serious underlying issue. So while calm treatment and stabilizing care and supportive care is warranted, you should maintain an index of suspicion, particularly as you rule out through assessment other potential dangerous etiologies. If signs for stroke are present, then you should treat accordingly and also inquire about what medications the patients may have taken, over-the-counter prescription or otherwise. For severe headaches for advanced level providers, you may consider medication for pain management such as Toradol or Ketorolac, and even opiate treatments such as fentanyl and morphine. For nausea and vomiting, you can consider promethazine or phenergan and ondansetron. Dementia. Dementia is a chronic deterioration of memory, personality, language skills, perception, and reasoning or judgment. These changes can occur over weeks and years, and it's important as prehospital providers to be able to differentiate between delirium and dementia. Dementia is a chronic disease process, and so the onset and the duration is a much longer period of time. And we'll talk about delirium a little more deeply here in a moment. Causes for dementia can vary from Wernicke's encephalopathy, which is caused from a vitamin B1 deficiency, Alzheimer's disease, which is progressive state in which neurons die. And again, I can't iterate the importance here of making sure that we differentiate onset time to be able to determine the difference between delirium and dementia. Dementia oftentimes can get dismissed as old age. It becomes obvious as time progresses that it's not simple memory loss. And late stage dementia patients can become aggressive and violent, especially if they're continuously confused about their locations, their surroundings, and their loved ones. Understand that the management for dementia patients is not just focused on the patient itself. You should also be aware of the impact it may have amongst family members. And it's not uncommon that when you arrive to the scene of a dementia patient, particularly if it's a frequent EMS user, that you will start to notice fatigue in the family members and fatigue in the bystanders and providers. And it may be prudent that that person seek additional evaluation and treatment, or it may be prudent to have discussions with the family about transitioning the dementia patient to a long-term care facility or engaging pre-hospital providers and community partners to help that process along, as those family members can become extremely taxed in dealing with these patients. As far as assessing the demented patient and manage that, follow your standard care guidelines. It's basic supportive care. Ensure that there's not a reversible cause present. So make sure you rule out through assessment things like hypoxia, hypoglycemia. For other reversible causes with Wernicke's encephalopathy, there's not a lot we can do to reverse the damage that's there, but this is the reason that we encourage you to give thiamine before administering glucose to diabetic patients, especially those that are malnourished. This disease process derives from a vitamin B1 deficiency, which is addressed by administering thiamine. Make sure for dementia patients, if the patient will allow, that we monitor ECG tracings for these patients, as we want to, again, rule out that there's not an underlying cause there. Neoplasms, pathophysiology, this is the growth within the body that occurs as an error during cellular reproduction. A neoplasm specifically is a cancer of the brain or spinal cord. Primary neoplasms are cancers that arrive within the nervous system, while metastatic neoplasms are tumors that spread into the nervous system. Signs and symptoms of brain tumors can include things like headache, nausea, vomiting, seizures, ataxia, change in mental status, and stroke-like symptoms. And spinal tumors signs can include things like back pain, weakness, ataxia, loss of limb sensation, incontinence of the bladder or bowel, as well as deformity of the structures of the spine. Again, with neoplasms, just like we discussed in differentiating between delirium and dementia, delirium is sudden onset, dementia is long term. These are typically long onset problems, and so make sure you're getting a history with these patients to see when did the nausea and headache start, the ataxia start. That information can provide valuable insight and help drive the continuum of care for these patients. Management for these patients is largely supportive, but watch for things like status epilepticus, and anti-seizure medications such as diazepam may be needed if the patient is indeed seizing. Let's talk about some of the demyelinating, degeneration, and motor neuron disorders. These are types of neurologic conditions that have similar presentation. So demyelinating diseases prevent smooth signal transmission between the neurons, while degenerating diseases are progressive damage and or death of the neurons themselves. And remember that the motor neuron is the signal or the pathway in which the brain uses to communicate with skeletal muscle to move the body. And when we have motor neuron damage, that's destruction of the individual motor neuron itself. Multiple sclerosis, or MS, is a common disease that we see within pre-hospital medicine. These patients are chronically ill. They have significant flare-ups. The disease is characterized by flare-ups and sort of recessions of the disease state. It's an autoimmune condition in which the body attacks the myelin of the brain and spinal cord, and the body then begins to attack its own cells. It follows, as mentioned, a pattern of attacks and remissions. Common complaints include things like double vision, blurred vision, nystagmus or shaking within the eyes. Other signs can include muscle weaknesses, speech disturbances, vertigo, euphoria, and electrical sensations. Management for these patients is, again, largely supportive, but be prepared for trauma related to a fall, as their coordination tends to deteriorate as the disease progresses. In-hospital treatment is aimed at controlling the symptoms, and you may need to consider pain management in the pre-hospital world if the MS flare-up is bad enough that the patient is in significant pain. Guillain-Barré syndrome, this is a rare disease in which attacks the immune system and portions of the nervous system. Patients typically report a previous respiratory or GI infection, and some patients can recover completely, while others require assistance for the rest of their lives. Assessment with these patients will start, presentation will start with weakness of the legs, and then it moves up the legs and affects the thorax and can lead to paralysis. The patients are prone to severe swings in pulse rate and blood pressure. Management, you're going to assess the ability of the patient to protect their own airway. This will largely depend on how progressive the disease is and how rapid the rate of progression is. If available, you should monitor these patients with ECG. So if a paramedic is on scene, they should be applying an ECG to these patients. Repeat vital signs as you would with all of your patients, but obtain continuous readings for end-tidal CO2 to help monitor for respiratory sufficiency, and be prepared to administer IV fluids for blood pressure support. Provide comfort for these patients and be prepared to manage transport ventilators and assist with ambulation, especially if the disease is progressive. Parkinson's disease is a neurologic condition in which environmental and genetic factors place the patient at risk for damage to certain neurons. Most specifically, the substantia nigra, the portion of the brain that produces dopamine, is damaged. It's hallmarked by sort of a masked face appearance, stooped posture, back rigidity. Typically, we'll have flexed elbows and wrists and tremors in the legs and the feet and the hands, particularly when they're at rest. For assessment of these patients, the onset is typically gradual. It's months to years, and the classic presentation, as mentioned earlier, is hallmarked with tremors, sort of postural instability, rigidity, and slow sort of shuffled movement. That's that bradykinesia term. Management for these patients in the pre-hospital world is supportive, treat any injuries, and in-hospital treatment includes levodopa. And in identifying patients with Parkinson's disease, these patients will often be described levodopa and or carbidopa. So obtaining that medical history, that medication list, can give you some insight into the patient's underlying disease conditions. Amyotrophic lateral sclerosis, ALS, or Lou Gehrig's disease, is a disease that strikes the voluntary motor neurons. There's no real discernible cause at this point in time, and it's most common in middle-aged men. Presentation for these patients, the changes are initially subtle and they progress without notice. These signs and symptoms can include things like fatigue, general muscle weakness, fasciculations or muscle twitching, and difficulty doing routine activities. Largely supportive care and the standard guideline of care for these patients is warranted in the pre-hospital world. But as with any paralytic disease, we want to make sure that we're at least monitoring the airway and ensuring airway patency, and be prepared to intervene if necessary. Transport can be complicated with these patients as they might be in a rigid postured state, and so you may need to get aids or assistance of the family members or caretakers that are on scene with that patient to help you position the patient in a manner that's appropriate for transport. In-hospital long-term care for these patients include things like physical therapy and mitigation of symptoms through various medications.